Men. So today's discussion comes as a pivot. Has never been more important. So this morning, we will explore how technology can help improve interoperability, strengthen compliance, and ultimately enhance patient care.
So a few housekeeping rules. Kindly keep your phone on silent. In case of any emergency, please feel free to alert us. But we have an exit to your on my extreme left. The washrooms are located outside the hall, and we are currently live streaming this session. We'll be using some of our live microphones to go around as the session keeps on going. So I think we'll kick off with our mentee.
Yeah, Menti, please. We want to see how everyone is feeling today. So you go to menti.com, scan the QR code. If you are unable to scan from wherever you are, menti.com, then enter that ID. Then there'll be questions that will be posted for you to respond to. So first question, how are we feeling this morning? Hopeful, excited? Someone is very happy, expectant. Wow. It's about that time when you need to. Yeah. Energized. Hope you've taken a lot of fluids this morning for you to get that energy. You're good. People are curious, buried in buyer. This room is warm. If you're feeling cold, take tea, hot tea. Cold, well fed, good. People are reacting with emoji. Keep it coming. We have 32 out of 37 responded. Fantastic and grateful. December in August. So people have started feeling the costs breeze here in Serena. Yeah, after this, you can visit the garden here. You'll feel that excitement. December is here. Tired. Oh, it is not even 8 a.m. Someone is tired. Yeah, I think with this session, then you'll get along the way, you'll get energized. We're good. What are your expectations from today's session? Solution. People want one system that will help them manage their problems. So you don't need to worry about that. Someone has taken care of a better understanding of the integration requirements. Yeah. Whatever you have, is it going to get in whatever is going to be introduced, or you'll throw it away? You'll get answers. Clarity, learning. As I said, for you to learn, you need to pay attention. When the speakers will be coming on the podium to speak, you'll get something out of it. Just pay attention. Product immersion, pricing. That pricing? How much? Sign up, connect, integrate. Better collection management. Understanding the partnership. Safaricom and Savannah partnering to help the providers have less pain at the point of care system. We need more? Yeah, so from what we've received, we've seen everyone is excited to see whatever is coming on board today. And the way you've seen the tagline is there is connecting to Kenya's digital health superhighway. we have the architects of all these that you're seeing here will have to explain what that means in broad. So being expectant means you need to get with something out of this place. So attention is the only thing you need to pay, and you'll get that going. So, Millicent?
Okay, so to help us set the mood and the tone for today's discussions, allow me to invite our commercial director, Joy Kiguta from Savannah Informatics, who will take us through that session. Thank you.
Karibu Joy, help us welcome Joy. It's a rare resource to get around.
Good morning, everyone. I feel like we are not yet warm, we're still cold, or the food has not yet reached haijafika chini. We've not digested. So I'd want us to just stand up for a bit, get a bit energized, look around the room, and see our peers. So let's stand, all of us. Greet the person next to you. Welcome them to this interactive session. A little bit more noise. I can't quite hear you. Do you feel a bit more energized now? Are you ready to ask hard questions, interesting questions, and get to learn from all of us? Okay, I think now we're good. It's a bit more lively. We can have a seat. So good morning, and thank you for choosing to spend the start of your day with us. We really appreciate that you are able to come forth. I saw most of you are getting in even before 7:30, which we do feel honored to have you. Look around the room. The people who actually run private healthcare are here with us today, whether it's CEOs, medical directors, hospital owners, our colleagues from the Kenya Healthcare Federation, and the technology partners who keep our systems running in healthcare. And a warm welcome to everyone joining us on the live stream. Let's be honest about why we're here. I've seen most of us on the Mentee have said we're expectant, we're looking for clarity, want to get an understanding of what integration means. So that's why we're here. Almost everything about how your facility gets paid is being written at once, where you submit, what's covered, what a benefit is worth, and how fast the rules move, and every one of you has felt it in the same place. The claim that goes out and doesn't come back. That is not an ICT problem. It's a cash problem, a payroll problem, and can I buy the next CT scanner problem. And the honest difficulty is this. The answer being offered to most providers is rip out what you have and start again. We know that most of you have already invested in systems that are working well, especially on the clinical side. Your clinicians have finally learned them. Nobody in the room has an appetite or a budget for a rebuild. So the question that we set out to answer together with Safaricom is, can a hospital become compliant and get paid in full without replacing its core system? And if you do want to replace your system, what does that look like for you as a healthcare facility? Our answer is we are able to overlay and not overhaul what you already have, because we do know that you've spent a lot of money as healthcare practitioners or owners of healthcare facilities to put in place what you already have. So it sits on top of your existing HMIS if you have one, and it connects to the national rails. So everything that you need to do to connect to the HIE or the digital superhighway is what we're able to help you figure out. If you have no system, as I said, our HMIS can be your system. If you have one and you like it, you can keep it. That's what we are going to discuss today. So we're going to have different streams of discussions being led by our technical team. So what does Safaricom bring to the table? It brings the reach, it brings the infrastructure that we rely on. And Savannah brings the rails. So that is the whole logic of our partnership. So what to expect this morning? this is how our day is going to run. So we'll have our CEO from Savannah, Dr. John Othe, who will speak about the partnership, how it came about, and what the two of us as partners are committing to. We will have Dr. Job Nyangena, who will speak on the national digitization mandate that this sits inside. We will have Dr. Ngure Nyaga from Savannah, who will speak about the technology and speak specifically about how your existing HMIS plugs in. We'll have my colleague Abiud Orina, who will show you how our HMIS actually works. You'll see it working. Then we'll have Julius Miner, who will speak about the commercial journey, what adoption actually costs, and what the ask is for your team. And then the part that matters the most is your questions. Please make them difficult, as I said. Ask the hard questions. Leave the room having clarity. Would much rather be interrogated over breakfast than after you have signed on. So, what is our ask to you? At the end of the session, as I said, ask as many questions that you have and also sign up. There are QR codes on your tables, on each of the tables, where you're able to quickly sign up. But I don't expect anyone to be signing up right now. You don't know what you're signing up to. So as we continue with the conversations and you're getting a little bit more interested, there's a link where you can be able to sign up for more questions, ask us more questions, schedule a one-on-one, or even if we have enticed your appetite enough, you're able to sign up directly into the platform. So enjoy the coffee, enjoy the breakfast, ask the hard questions, as I said, and let's get to work. Enjoy the morning.
Asante sana Joy. Makofi for Joy. Thank you very much. We know for every successful digital transformation, we need to begin with a shared vision. To help us understand this, the journey that has brought Safaricom Business and Savannah Informatics, help me welcome Dr. John Mudhe, CEO, Savannah Informatics. A CEO at this age is something I'm looking to. It's still on my bucket list. Karibu sana daktari.
Thank you. I came over here today because a lot of you have been calling me. I've gone through an integration journey with your technologies for more than about 13 years or 14 thereabout. So most of you are asking, tunafanya hivi tena? And I think in partnership with Safaricom, the last couple of months, the last 2 years, and even 5 years back, we've been looking at how to mature the digital ecosystem in Kenya when it pertains to healthcare and how to support what Savannah's vision is, what Safaricom vision is, and importantly, our technology partners, the vendors who have worked in the hospitals since we started our business about 14 years ago. So where I'm here today is, first of all, to be able to clarify to all of you instead, one by one, that we're here to support you. That's the first thing. The second thing is that we built two things. We built the SHA provider portal in partnership with the payroll and DHA. We built the National Health Information Exchange in partnership with Safaricom. So we have had quite some experience there. And now we are saying that from our knowledge across those two product lines, we are able to work with you in a way that either you can connect to some of our technologies with your current technologies, some of our APIs using your current technologies. If you had a plan for a new HMIS, it's also there. But we are able to openly tell you what were the ingredients that we had when we were working on both. And why would Savannah, after building those two technologies, the National HI with Safaricom or the provider? Sorry. This has died. Hello? Hello? Yeah, I'm back. And why, after all that, would we want to do that? The first thing is that the journey to compliance, we need to shorten it. So how do we offer a pathway for any corporates private, public, and reduce the double work as you work with Savannah, as you work with Safaricom, as you work with your vendor, as you work with your internal IT team. I think that's important. But then, even as we do that, we believe that we have a responsibility to you as our customers, our partners, and the vendors that we have always worked with. How, as a provider portal engagement, it has been carrying 100% of all the SHA claims. We carry some of your private sector claims. But how do we work together in that transition? In a way that change what you must change, but what is working, figure out how to get certified for that. But also, whenever we work with you every day, we observe regulatory velocity. We order those release notes. We release them at very interesting hours. We put them on Beamer in the morning. But how do we work with you in a way that you are aware of what's coming, in a way that you are prepared for it? You, your vendors, your clinical team, your CFO team, and the like. If you could go to the next. So it is because we believe that you have already worked on how to protect your revenue. And if we have a product, Slade Advantage, how do we help you at least uncover some of the challenges early on? And for what your technology is able to absorb from us, it absorbs. For what it needs help from us, it gets that help in a way that we protect our revenue. Thank you. And I wish then to ask my colleague in the industry, Dr. Gakombe, to come and just give us 5 minutes why sometimes an ecosystem play is what is best for everyone and how we can all partner even as the industry is changing rapidly. Thank you.
Thank you, Dr. Mode. Good morning. I stand here in a number of capacities. First, as a friend of Savannah and as an older brother to Dr. Mode and his crew. 2, as a director of the Kenya Private Sector Alliance. 3, as the chair of the Kenya Healthcare Federation. 4, as the CEO of Metropolitan Hospital. And 5, as a technology entrepreneur, because we design and develop systems. From a KHF perspective, we are very, very keen on digitization because we see digitization through an ecosystem approach as both the glue and the catalyst for universal health coverage and for the enhancement of quality in healthcare delivery. We see it as a source of efficiency and effectiveness. We see it as a means to serve patients better because patients move from provider to provider, and it is important that as industry players, we mirror that behavior, and wherever our service recipients go, they should be able to get quality and affordable healthcare. From a provider perspective, many of us are increasingly being paid by somebody other than the patient. Those who came before me had a fairly easy time because the patient paid your receptionist in cash and you collected the money at the end of your working day. And that was how far claim management went. Today, we have one patient with multiple payers, some as many as 4, and the money comes from somebody other than the patient. And hospitals and providers lose money by waiting for long periods and by having a significant number of claims rejected. And part of the reason I went into the space of developing a system was because I realized that we are getting about 70% of the money that we are claiming after 90 days to 2 years. And I believe I'm talking for some of you when I say that. And when we looked at the issues that we are dealing with, we realized that many of them could be addressed by having a digitized ecosystem within the hospital. And our claim losses decreased to something like 2.5%. And in many instances, we are able to recover 100% of our claims. It's even more complex today. And there is no choice but to run on an ecosystem basis. So I am very, very happy to be here. I am a customer of Safaricom of long standing. I don't know what people get on year 20 and year 25, because we enrolled as soon as Safaricom came on board. And this new space is a very important one for us as an industry, because you need big players to provide the infrastructure and the connectivity for the rest of us to plug into. And since most of us have systems, the idea that we'll now have a plug and play arrangement where we do not have to change what we have is music to the ears of many providers. And the fact that Safaricom is in this space, partnering with experts in the healthcare space, means that we stand a far much better chance of success, because whatever else Safaricom may not be, Safaricom figured out something I was taught by a Swedish professor many years ago, that the easiest way to be rich is to get other people to do the work and they pay you for the pleasure. So we all are workers for Safaricom here. We send each other money, we pay through pay bills, but we don't complain because the alternative would cost us far much more if we are to attempt to do that manually. Has it been done before? Yes. Safaricom itself, what we call M-Pesa as an innovation. The innovation was digitizing something that we used to do when I was in high school, because my father used to send me money by telegraphic money order. And those who are my age know that a telegraphic money order was somebody going to a post office and depositing money and then calling the post office in Mombasa to say, I've deposited money to be withdrawn by John Mothe. And the post office was the agent. It's now much bigger, much faster, much more efficient, much more safer, because it runs on a digital platform. If we are still doing that telegraphic money order, chances are that there will be maybe 100,000 customers. Now there are many more, because digitization offers scale and scope. So I'm very much looking forward to actually connecting as an institution, enhancing what we do, and following the example of the stock exchange where I used to work, where money came in 90 to 180 days if you wanted to sell your shares, to today when it is transaction day plus 3 at most. And in some exchanges, it is transaction day plus 0. So I am hoping that one day, when Safaricom and DHA and the HIE and Savannah and Smart have really become smart, we providers will get our money in the same time it takes to get money through M-Pesa. So Safaricom, that's my challenge to you. Can you do for us as healthcare what you have done for individuals who transact through your award-winning and pioneering M-Pesa platform? So let's get on and do it in a way where each of us stands to benefit. Thank you.
Wow. Asante sana, makofi. Ile mvua. Thank you, Dr. Mudhe, to have introduced Daktari here looks like he know a lot in this space. Asante sana. And hard questions have been posted. Someone somewhere, you need to take note about that. Asante sana. So we know partnerships becomes even more impactful when they align to national vision. So we'll be joined here on stage with my boss, Dr. Job Nyangenda, to share Safaricom digitization mandate and why this partnership is extending those capabilities to private sector healthcare. Karibu daktari.
Thanks a lot, Ngosi. The marvels of AI in the profile pictures. So, number one, challenge accepted, Dr. Gakombe. I don't know if we can send you claim money as fast as it takes to get your you have received message, but tutajaribu. Also, sikusikia makofi when Dr. Gakombe mentioned his 6 substantive positions. So let's give it now. Currently, I can only say I'm the digital health lead at Safaricom. I need to add those other 4 or 5 positions. So my name is Dr. Job Nyangena. I lead digital health at Safaricom. So first, I think this partnership so far from what you may be getting or understanding, or when you see such a poster, is Safaricom is bringing the technology, Savannah is bringing the industry expertise, but Safaricom has shown a commitment to building its health capabilities. It's had a whole team, almost 50 individuals who are extremely experienced in the health sector as well. We have doctors, we have pharmacists, we have software engineers who are who've worked in the digital health space for years. And so we're also bringing a wealth of experience in healthcare. So we have a vision to be a purpose-led technology company in Africa by 2030. And that means a transition from a telco to a tech company. It's an ambitious vision, but what this means is we are going for platforms as opposed to applications per se. And a platform play is basically an enabling play. So we're not pushing anyone out of the ecosystem, but we are enabling you to operate better. And so that's our commitment. We're bringing a lot of experience in our traditional businesses. We're bringing a lot of experience in our connectivity business, our cloud and digital infrastructure business, our fintech business, our enterprise and public sector digitalization experience. And on this, I wanted to double click on our digital infrastructure business because I've been getting a lot of calls recently when this partnership started being advertised. And there are a lot of hospitals that are greenfield. They don't have a system. And the first question they're asking is, I need to know what I need to buy in terms of the infrastructure. How many computers do I need? What connectivity do I need? So even before we get to the issue of the solutions we are talking about here, the people who at the very basic level, they still need that support to support the infrastructure at the facility level. And we have the experience to provide this. Of course, Savannah, you know them very well. They are industry leaders, especially in insurance tech. They also understand clinical workflows. They're led by experienced health experts. And so this is almost a marriage made in heaven, that we're going to support the ecosystem, enable it to achieve whatever Dr. Gakombe talked about here. And so we're not just giving you a solution in terms of this HMIS system, but we are inviting you to help us build this ecosystem that will allow the vision of interoperability in health information management come to life. You should be able to manage your branches better. You should be able to have proper follow-up of patient care, continuation of care from one facility to another. So all this is what we are enabling. And we're bringing the entire support that Safaricom can provide from an enterprise perspective. And in that regard, I wanted to invite our lead from Enterprise Business Unit, Mr. Alan Kipsang, to just give you a sense of what the enterprise support you can get from Safaricom as we roll out this partnership with Savannah. Bwana Alan.
Thank you, Dr. Job. Good morning. I know it's a cold morning in Nairobi, but we can warm up, right? I think speaking after great leaders at times inspires a lot. I would remember a few years ago, we would dream that we would have interconnected systems, ease of access, and ease of operating. But that time is now here. And you will believe with me, everybody is speaking about how easy today to get information. And as I interact this morning with the digital health professionals, I'm fully aware that those are the opportunities and the challenges that we see equally that are turning our plate into our ecosystem, because we serve consumers of health facilities, we work with interconnected partner ecosystems, and we also comply with the ever-evolving regulatory in the industry. And biggest questions include, how do we then adapt so much fast enough to be able to then meet the pace at which the world is changing digitally? At Safaricom, and Dr. Job has made a good remark around our transformation agenda, that by the year 2030, Safaricom will be that leading purpose-led technology company of choice. And we will not do it alone. We'll do it with our partners. We'll do it with you, the players in the industry, to be able to make that possible. So what does it mean to transform digitally in the health space, and where we see the Safaricom? Of course, we take the pride that over the years, we have seen a lot of success in terms of how we build the digital infrastructure, not only from a secure connectivity, but also from the data information and network infrastructure that we have today, but also in the platforms that then provide this ease of access, and then the experience that then the ultimate consumer will be able to do. So our guarantee that we give you as we partner this morning, not only from addressing the needs of those consuming these health services, is that Safaricom will be at the core center to be able to work with you the journey, to transform. And I like the challenge that we've been given this morning around how do we make even the claims and the hospital processes and the clinic processes much faster that we have experienced today on the payment space. I can guarantee to you that we are actually working together to make sure that speed is evolved. How will we solve it? Because when we have this interconnection of ecosystems, right, not only from HMIS, but also how you integrate with the other players that we work with, it then provides us an opportunity to be able to accelerate. But also, how do we make sure that we have that reliability from a service perspective? Safaricom gives you that guarantee that we should be able to work with you the journey to make sure that we at least are as up as what we have today on M-Pesa, which we guarantee uptime, as up as what we have today on our network ecosystem, as up as what we have today from the people perspective in terms of being available to be accessed from where you operate as health service providers. I can't imagine such a great time than this morning when we're actually launching that journey to begin the transformation. As we all know, digital transformation is not a one-day event. It's actually a process. So we'll work with you the journey to ensure that that is guaranteed, and then that is able to enable you to excel in terms of service delivery to your customers. With those few remarks, I would like to thank you and at least give our promise that as we begin the journey, not only to transform our systems, that we will be there with you day by day to work at that particular journey. Thank you very much.
Thank you so much, Mr. Alan Kipsang and Dr. Job. So without further ado, allow me to introduce Dr. Ngure Nyaga, who's our Chief Innovations Officer. Thank you. A round of applause.
Morning, everyone. It's great to see you all this morning. Just click on the next. So as the speakers before me have all noted, every hospital here, other than a greenfield, has an existing system. And so the question becomes, are you expected to, in a matter of weeks, rip out and replace something which took you 2 years, 1 year, 3 years, however long it took to put together? And we think that for a lot of you, the answer can potentially be, no, we don't expect you to do that. And I'll explain how we think or we propose to help you navigate that journey. So throughout the session, we'll talk about the options you have. And the options you have might be an option where your current system is close enough, modern enough to actually adapt and connect to the superhighway directly. Safaricom and Savannah happen to be the team that was contracted by DHA to build out the digital superhighways middleware or connection layer. And would be happy to work with you on the compliance journey, including providing you with guidance and knowledge. It might be that your system is very well established, but it needs to be complemented with maybe an additional connection, maybe some additional interfaces, so that the whole thing together, the combined bundle, is able to plug into the superhighway and is able to become a compliant, certifiable bundle. That is the connect option. And it's possible also that either you're starting out or you're at a point where you have the willingness and the appetite for a migration, which will be migration into a new system, along with the data migration and the training and other things that come with that. Then the constraint that we face right now is that for a lot of us, we don't have the luxury of time. We are on the receiving end of multiple mandates by law and regulation that need us to respond. So there is the mandate to transition from the SHA portal and connect to the digital superhighway. I believe it's a deadline in September. There is a mandate which has been there for the last year or so, which is the mandate which is the mandate to fiscalize all invoices. And for those of us who have got a private insurance business, we've already been at this place where your claims don't get accepted for processing unless the invoices are fiscalized. And our businesses, our hospitals are more than just insurance. They have cash billing, they have SHA, they have many private insurers, they have employers and corporate schemes. And our approach to this product that we're calling the Rail is an approach that is aimed at helping you adapt and connect to all of this. And not merely just SHA and claims, but also bridging you to private sector insurance claims through ourselves, through our partner Smart, and through any other networks that are around in the sector. Right. So I'd already mentioned that at this moment, we don't have the luxury of time or the option to wait. And I think everyone is having to make this decision. Do you stand still and wait for the deadline, or do you move? And the choice is not binary. It's not stand still or replace. The choice is a choice that might involve options where you continue to run your system and it is modernized or it is connected to the overall ecosystem. So my colleague Dr. Mode mentioned this. So in terms of approach and mindset also, we'd like to encourage everyone to take a viewpoint that goes beyond claims. So claims are important. Claims are urgent. It is a now need. But are we at a point as a sector where things we've long dreamt about, secure referral from facility to facility, e-prescriptions done right, orders for diagnostics sent to hubs and done right. Done right means done in a manner that complies with the law, privacy, and all that, yeah? And as we work with you on this journey, as much as the urgency and the pain and the pressure is centered on claims, we think that there's opportunity to broaden our minds beyond just claims towards a much more connected healthcare ecosystem. So let's look through the options that a hospital that has an existing system has in front of it. Option one is get your developers, your system vendor, working with knowledge documentation which can provide and support to make the system certifiable, to comply, to build in the workflows, to build in the connections, to test the whole thing, to get it certified. And if your system is already quite modern, your vendors are already quite responsive and quick and fast, or you have an in-house team that has built it and they are very, very, very much on their game, then it's an option that's viable. Option two, you have an established system. And when I say systems here, we recognize that a lot of hospitals have more than one. You might have an ERP, an Navision, a Sage, an SAP that is handling the money, a HMIS that's handling patient administration. And those systems, there's a possibility to connect them to the rail so that the combined IT landscape is together compliant and is together getting you on the rail. And I know some may wonder, is this possible or not possible? While I cannot give a blanket answer in a setting like this, it's an answer we can give after we visit you, and it's something we've done in the past. I remember many years ago, 2013-14, Dr. Mode, as was starting Slade, no one believed that you could do system integrations. You mean you can connect a hospital to an insurer? Not possible. Then it became possible, it became routine, it became everyday. And maybe there's an opportunity to use lessons acquired from that journey to help hospitals move onto the rail without very, very destructive rip and replace. It is possible that you've got an existing system that was already approaching a point where you are contemplating replacement. And if you are, then the option to work with you and evaluate a replacement and migration is available. And that will be a choice that is taken, I'd say, hospital by hospital or network by network. And I'm glad to note also that for us as ecosystem players, we hope to see an ecosystem that has many options available for this. So the option you could take for this could be ours, it could be one more. When we work with you to evaluate your options, one of the things that will be key in deciding what is the most viable option will be the assessment of how viable integration is. Now, the actual assessment is more detailed than this, but you can see sample questions of the kinds of things we'd want to find out together with you, your IT team, and your system vendors or your developers. Is it actually possible to integrate? No, the system is completely closed. We may have the wish to integrate, but the viability is not there. Or the people who build the system, are they on board? Are they aligned? Are they going to work with you on the integration, on compliance? If the answer is yes, it makes that a lot more viable. If for any reason the answer is no, it makes that less viable. And there's a matter of time. And unfortunately, we are all acting under time deadlines that are regulatory, which means we have to evaluate options and select the paths we take at our facilities in a fairly short amount of time. So the reason why we invited you all here and why we wanted to have you, it was to introduce the fact that the range of options is larger than simply rip and replace. There's an option to adapt, which is essentially your system modified to comply and connect. There's the option to connect or to complement it, to wrap around it, to integrate, and there's always the option to replace. And those options might not necessarily be mutually exclusive in the sense that given the timelines we're all working under, which are very compressed timelines, it's possible to start at a step where you complement the system and then work your way gradually over time to a different point. I remember a few weeks ago visiting a very large faith-based hospital, and the one thing I came back with from there was that if anybody attempts to replace this, it's a 2-year project. Because when someone is replacements. And I had another visit also to a very large faith-based hospital where the situation turned out to be the opposite. On an older system, Windows-based, with a pre-existing decision to look for a replacement and migration being viable. And all those are very, very, very valid choices because all those choices are contextualized to the provider and their current circumstance. Then I think we'd be amiss to talk about this and not talk about data and access. For the long-term health of the ecosystem, vendor lock-in is not a good thing. And I think one of the things I'm glad about from the Digital Health Act, the regulations, and all the laws the country has enacted in the last couple of years is the fact that it provided a framework for data to be standardized. When it's standardized, it is portable. And it means then that no one is held hostage and you stay on the system because it's giving you value, not because you have no choice but to stay on. In this room today, we have our colleagues from the industry who are system vendors. We have our colleagues from SMART. We have our colleagues from AMS. Dr. Akombe spoke here. And we're very glad that they honored our invite because we firmly believe that the correct way to do this for the country and for the ecosystem is to do it with an ecosystem or a platform mindset, where we are actually quite happy to also work with vendors who have existing systems and deployments to complement each other. Take what works, bridge and join with what needs to be added, and then the whole thing provides way more value for the hospitals than any of them alone could. Now, in terms of working out where you fall, and this will be my primary ask, the way to figure out what is viable for your particular IT landscape is to allow us to conduct a short visit to your site. We call it discovery. And it's a visit where, working with you, we work to figure out what do you have, can it be connected, what's working well, what's not working well, what's already very well trained and built into your workflows. Does your IT team have access to the system? How is your vendor? And then we've got answers to those questions. We're able to give you a very, very, very honest assessment and plan that lets you know that we think it's viable to connect because of 1, 2, 3, and the plan will look like this, or we think it's viable to support your system vendor with this connection integration, it would work this way. Or because of this barrier and that barrier, it's not viable in the amount of time we have to connect. Let's evaluate other options. So at this point, I'd like to hand over to my colleague Abud. I've spoken through the general framework, and I think the words to remember are the words adapt, connect, replace. Make what is there compliant by evolving it, or bridge the rail and the system, or consider migrating. Thank you.
Makofi kwa daktari. Yeah, as Abid comes, we've really learned a lot. This is a medical doctor who has mastered engineering in the healthcare space. This guy, allow me to call you this guy. He has really done well, and whatever he has talked about, he's backing it with data. He's an evidence-based doctor around. So Dr. Ngure, makofi kwake tena. So for us to cement what I said and put into perspective, Abud, who is a software engineer from Savannah Informatics, will demo the solution that we are bringing on the table. Karibu sana.
Good morning. My name is Abud Orina from Savannah. I hope the tea is settling in well and you're warm enough. So I'll do a quick guided demo of the product. So before we begin, there's a lot that you can cover on the platform that you couldn't be able to package properly in this demo. A full product demo takes about 3 hours and around 23 minutes, which I don't think everyone has at this time. So we'll try and just a guided demo of what you're interested in for this session. And then in case you need to understand the system more in depth and how it suits your requirements, again, I'd like to iterate the same things Dr. Ngure said. If you want to adapt, how you can modify your system to be compliant. If you want to connect, how you can integrate into the platform so that data flows through your system onto the HIE through Advantage. And then in case you want to replace, you can also get in contact with us. And then finally, the product, I think from what we'll show in the product is mostly how it does a guided patient journey end to end. So we can begin. So yeah, and then so the platform is packaged in different modules that you can configure for your facility. Each module does its own thing. So for example, clinical, and then the modules are guided and categorized according to the categories. So I can't see. So the modules are categorized according to different categories. So you can see there's the front desk, front office, which handles everything to do with front office. There's clinical, there's financial, and then there's credit control as well. Then there's also back office for any admin task that you want to do. And then finally analytics, among many others. So the single point of contact for the patient is at the front desk where they come to your office for registration. So in this case, it's mostly a list of the patients that you have in your facility. So in this case, for example, we are searching for the patients that you already have. If you're not able to find them, you'll do a patient registration whereby you click on register. Sorry, allow me to step down. I can't see properly. Yes, so you can do a registration against the client registry by searching through the available identifiers. And then in this case, we have our patient that is ready to be seen. And then this is a view of the patient profile, and you can enrich with as many information as you need. And then so things like contact identifiers, emergency contacts, consent, and legal. And then when you're ready to see the patient, you will now do a quick check-in of the patient to basically configure the visit. So it can either be a new visit, a returning visit, and then there can be configurable visit types depending on how your operations work at your facility. And then the second part is billing, whereby you configure whether this patient is a cash patient or a credit. For cash, you can choose to pay now or pay later. So in this case, we'll proceed with the credit visit to showcase the various methods in which you can bill and also give services to the patient. So in this case, if you can see, this patient already has 2 covers which require consent from the patient to view. So there's a Savannah cover, which is our in-house cover. And then you can also do the SHA cover as well. So I think in this case, we've already done the patient check-in, of course. And then, of course, for the patient profile, there's a lot of things. So there's eligibility, there's authorizations in case you want to do any authorizations, pre-authorizations for any service that need to be approved, billing. I think we'll cover that in a moment. Invoices, any orders for the patient. So basically, it's an overall view of the patient's profile. Then I think for this section, we'll go through the eligibility. So I spoke about the SHA cover. In this case, for this scheme, our in-house scheme, the patient will have the card with them and you'll grant access to that cover. And then if you have the cover, you can now view the details. In a real world scenario, this will be done through biometrics as well. So in this case, we are choosing one of the benefits. In this case, it can be outpatient. And then you can see there's different authorization methods are configured depending on the settings and regulatory compliance. For example, I think recently mostly OTP has been outlawed for security and compliance reasons. So, and then you can see we already have biometrics. So the patient will authorize access to this cover so that it can be used for giving them care. You can see the configured fingerprints from that section. And then now this creates an authorization using the fingerprint method. And you can see the authorization has already been created for this private cover. And then we'll quickly cover the SHA side as well. So the same case for SHA, there's a requirement that the patient has to be basically at the facility before you are able to give them care. So here we are basically viewing the how you can access the patient's benefits from SHA. So in this case, I think we had already done like a pre-authorization for fingerprints prior to this. So you can be able now to see the patient's interventions from SHA. We'll choose one of them, for example, renal care package, whereby now we'll create an authorization against an intervention. In a real world scenario, you'll be able to configure as many interventions as you need, depending on what SHA requires. So as you can see, we're also authorizing biometrics using an iframe from eCitizen, whereby it gets the patient's fingerprints, and the patient is now currently going to do an authorization using their fingerprints as well. And then, so you can see the fingerprints are red and the successful. And now this now creates an authorization for the patient now we can start care. So we've looked at those 2 methods. So there's SHA and also private. Any others are also done in the same manner. Then I think next what we'll do is a quick view of the authorizations that we have. And then, so for example, you can see the benefit itself that was used, the intervention in this case for SHA. Then any statuses, expiry details are also available, depending on how they are configured. And then the next stage is what we'll cover now is billing. So I think you've already seen the pre-authorization. So if you need to do a pre-authorization, there's also a provision for us to do the same. And then the next section now after this, so this is mostly a preview of how the pre-authorization looks like and the things you can add to a pre-auth. So charges, attachments, any practitioners, any doctor's approval that needs to be done, those are also covered in this section. And then the next stage is now billing, whereby we're going to add bill items to this patient split by payer. So if you want to do private, if you want to do SHA, the patient can also pay out of pocket depending on the requirements. So we have the notion of a service point and also configurable price list. So I know your facilities will have different price lists for different payers. So that is also configurable as well. And then in this case, we are going to do a consultation for this patient that is going to be billed to SHA. And then there's 2 ways you can split the bill. So it can either be one bill item split to one payer. So each item can go to a different payer, or one item can be broken down to 3 payers. For example, if an item costs, let's say 100,000, 50,000 can be covered by SHA, 50,000 can be covered by the in-house cover, and then maybe the patient can also pay any extra amounts out of that. So here we are basically adding now items to the patient's bill, which is now going to be visible in the final bill when we complete the visit. So I'm adding a few things. So you can see we've added consultation bill to SHA. We've added an ultrasound that is billed to now Savannah, which is the in-house cover. And then the patient will also pay for a liver function test using their own money out of pocket. And then once we add the bill items to the patient's bill, those are now visible at the front desk. In this case, billing can be done from anywhere. So if a patient goes to the lab and there are bill items there, they are all visible in their billing profile. So those are things that you can see, and then you can see the different service points that the patient has gone to, and bill items have been added. And then the last thing now we'll do for billing is to record any payments. So we have multiple payment methods. So as you can see, the patient's bill is already pre-filled. All the calculations have been done. And then for payment methods, the platform handles all types of payment methods. So PesaPal, M-Pesa. For M-Pesa, you can do an STK push, or you can query the amount in case the patient has already paid beforehand. Then we have a PesaPal integration as well in case you have the PDQ machines. And then you can also record cash, which is mostly not the preferred method currently because of revenue leakages and things like those. But it's also available and configurable on the platform. Then we've already recorded the patient's bill. So this patient's bill is finalized. So I think from there now we'll probably add an extra item, for example, to show how you can also build something else. So it was going to be, I think, the same ultrasound for the patient, no consultation. So this is mostly a repeat of the billing process. There's the split option as well, where you can split this amount, 3,000 shillings, to different payers. And during claim submission, that amount the claim can be sent to each person individually, to each payer individually. So 1,000 will go to Jubilee, for example, 1,000 will go to Savannah. And then depending on how the payer configures that visit, then any required attachments are added. Then before we complete this visit at the front desk, there's the notion of locking the visit so that no other things can be added to the patient's bill. And the patient has to authorize for each payer that we have added. So any public, for example, SHA, the patient will have to authorize through biometrics or any of the configurable methods available. And then in this case, we are mostly authorizing for the final bill now to be sent to Savannah as the final claim. So again, the patient will use their biometrics to authorize this whole visit and this bill amount. So mostly it's done at the front desk to ask by the receptionist to confirm that for the patient to confirm that this is the full amount. And then now at this stage, the front office person can also do some quick quality checks on the claim. So they can view the claims that have already been generated from this visit. They can view the details of the claim. So for example, this is a Savannah Informatics scheme. The claim status and readiness are visible there. And then any required documents, we'll show that in a few moments, whereby we have automated checks on the platform depending on the configured payer, where it can tell you that these documents are required before you submit this claim, so that you can act early before you get any rejections. So these are mostly sections of the claim. And then once the front office person completes this, confirms that all the relevant documents are attached, they will now complete or close the visit or lock it, so that now the credit control team can take over. So I think that's the end of the billing workflow. So next, we are going to cover the credit control. So now after the visit has been locked, the credit control team now takes over. But before that, I would like to quickly show you how, so I think when you go to the claim, later on, we'll see there is a pre-configured diagnosis which is required, for example. So in this section, we'll quickly preview the clinical workflows, not in too much detail. There's a lot you can cover for clinical alone. It takes about 20-30 minutes to show that. So we have the consultation module or application that handles anything to do with clinical. So triage, consultation, booking of appointments, and all those sorts. So we have a work list of, so basically in the doctor's room, they'll have a queue. So that is what is already configured. And then this is a pre-staged visit that we are looking at, a doctor's consult. So it has around 5 sections. So the first section is just to review how this patient has got here. So things to do with triage, what the triage nurse entered. So those are sample vitals that have been entered. And then the chief complaint entered during triage as well is available. And then any allergies, problems, those are just confirming before you start seeing the patient. And then in the second step is where you collect things like the history of presenting illness, basically the patient's history for any medical things you want to record. So any clinical notes are done in this section. Then in the third section is where now we'll do a detailed review of the systems. So mostly in case the patient has come with something else, you as a doctor or a clinician, you'll know what to do. And then you'll give a provisional diagnosis where you can order tests, labs, medication, tests, any procedures you want to do. In this case, we'll have already done the tests and confirmed that this is the diagnosis that this patient has. And then any lab orders can also be ordered from this point forward. Radiology as well, procedure. So we have different applications that can do all those workflows. And then the fourth step is the treatment plan, where now against the diagnosis, you can order some medication, add any additional notes. So any counseling you give to the patient, those can be recorded there. And then any health education segments as well, they are configured on the platform. So in case you have an automated health education program you want to run, that is also available. The final stage is now where I'm confirming as a doctor that this is what I've entered for the patient. So it's in a summary format where I quickly review the notes I've entered for this whole consultation, and then I can sign off for this visit. So for the first iteration, we have a click to sign. As the platform evolves, we are going to add now biometrics, which is already integrated on the platform from what you saw earlier, into now the doctors signing off. So the doctor can also sign off using their biometrics. If they have a tablet, if they have a laptop, that is configured. Then in this case, now we'll sign off on this exam so that the diagnosis we entered during treatment can now be visible in the final claim. And then a point to note here is that anything that is added to the doctor's, to the patient's profile is added to their shared health record, which is visible here. In case you want to print a visit summary for your hospital records, you can view that. And then the final endpoint after consultation is back to billing, where they can now confirm that the claim has been done. So I think the other section now, what you can look at, I think we saw how the front desk person completes the claim and logs the visit so that the credit control team can take over. So now in this section, we are going to have a look at that as well. Again, all basically, depending on your configuration, you will not have access to all these applications. For example, the credit control team will have access to just the credit control application that can be configured from your facility admins once you onboard you. And then on credit control, of course, there's a dashboard for all the platforms. We'll talk about that in a moment. This is now where the credit control team can manage all the facility claims, depending on payer. They can filter by status, by the payer that you have configured on the platform. They can filter by status and also by readiness. Earlier on, I spoke about claim readiness checks, which are automated and configured by, depending on the payer that you are working with. So for example, for our in-house cover, or for example, SHA, for this intervention, it's mostly going to have some set of required documents that you have to add before the claim review. The review team on SHA can have a look at your claim. So we try to front load those details upfront so that you can quickly check to reduce any rejections or any sent-backs from the payer. So these are automated. So for example, you can see there's some missing things that the provider needs to add. So in this case, they can now go back to the claim, to the visit, and adjust the relevant details. And then there's the check readiness button, which in most cases will be automated. But in cases where you've already attached the documents and you want to preload the claim, those can be reloaded as well. And then the checklist will keep going on as you move. So these are mostly the build items for this claim before you submit. Any co-insurance is also indicated. So depending on the insurance, what they want, that can be available and provided on the platform. The diagnosis you saw me enter in the clinical stage is also visible here. And then you are also given indications of the required documents that you need to attach. These are mostly attached automatically on the platform. You are not going to do any uploads because the platform already is integrated. And then From here, once you submit the claim, of course, there'll be transition logs. So on the platform, we've configured in such a way that once you submit the claim and the payer receives the claim, any status changes from their side is also visible on this platform. And so, for example, if a claim is dispatched, so you can see me viewing a dispatched claim, and then you can see the same details that were entered. And then there's a section called transition logs, where you can view now the journey of the claim from your facility all the way to the payer. So you can see, for example, this one changed from draft to dispatched, and then in external statuses, maybe from the payer side, if any rejections come back, those are also visible here. Then we have the notion of batching your claims. So depending on your facility operations, most of the day-to-day activities and maybe at the end of the day, and during the normal operations, the claims will have done all the checks and all the claims will be ready for submission. So you don't need to submit a claim one by one. You can add them all to a batch sent to one payer. So for example, in this case, we're just submitting this list of claims to Savannah Informatics, which is our in-house cover or payer, and they are sent as a batch to that section. Then the final or the second last section is mostly analytics. So most of the operations on the platform are, so the analytics is basically built into the platform. So you can see, for example, if you go to the front desk, you saw all the applications start with a dashboard that is already configured. Yeah, so all the applications start with a dashboard where you can track. We have three levels of dashboards. So there's the high level overview, so the executives, where you want to track all your facility operations. So I think that's what we'll show. And then, so for example, we can start with now the first level, which is executive overview, where you can have a bird's eye view of your operations for the whole facility. And then you can see, for example, in this case, we are looking at the overall service delivery for my facility as a manager or a CEO or a director. For financial performance, how am I doing financially, or how is my facility doing financially? Demographics, so what is the demographics for the patients that visit my facility? And then I can also now indeed do a drill down in detail for my financial performance for things like revenue analysis, costs. You can also review those. And then there's also RCM, which is mostly revenue cycle management, where you can track the status of all your claims in the facility and depending on different statuses. So for example, you can do like an overall overview. Then you can do things like claims throughput, submissions, collections, account receivable, any rejection that you have, those are visualized on the platform. So this is a demo system. So most of the data that you're seeing is for testing purposes and for demos. Then you can also review provide operations and also clinical performance. So things like medication access, diagnostics and labs. So we have a whole suite of applications that as the day-to-day operations proceed, this data is updated in near real time, and it can be configured depending on your operation. So if you want this data to be updated maybe every 2 hours, every 1 minute, every 5 minutes, that is configurable and available to you on the platform. The final one, I think we already talked about how you can connect to the platform or integrate. We have a developer documentation page, which has a list of all the APIs that are available on the platform, and you can peruse through and look for what you're looking for. So for example, if you want to see the full API reference that is available on the developer portal, this is mostly going to be interesting for the tech people or the facility IT admins who will want to integrate, or the software vendors who want to now adapt your system to comply with HIE. So we have all those APIs that you can view here. So they're split between different. So there's communications, visits, message groups, claims, products, user setup. So everything you just saw me demo here is available as documentation on the platform. And this documentation is updated with every release that we make, and it's available to everyone to view. I think that comes to the end of our demo. So these are mostly details on how the APIs look. So we've now I'll go back here. So I hope you have a rough overview of what the platform can do. And Like I said earlier on, the three goals, we've looked at what the platform does, from front desk, from clinical, from credit control, how you can submit your claims. We've looked at billing for SHA, private, public, depending on how you've configured your operations in your facility. We've had a look at the clinical module as well, which handles everything to do with clinical. So anything to do with things like triage, consultations, lab, pharmacy, all those are available on the platform. And then we've also looked at how the day-to-day operations in your facility feed into a dashboard that you can quickly review as you go on. So adapt, connect, and replace depending on the decision you'll make from this session today. I think the QR codes are now on your desk, so you can quickly scan after the meeting. I think we'll get guidance for the next steps. You'll scan the QR code, you'll book a session with our team. So depending on your operations, if you want to adapt, if you want to connect, we'll do a discovery from what Dr. Ngure said. And I hope to see more of you from the guided demos that we'll do together. Thank you, everyone. Have a good day.
Thank you so much, Abid, for taking us through that lovely demonstration. And clearly it shows how hospitals and providers are able to connect to this upcoming technology with our new HMIS. So allow me to invite Joy over to just carry out some exercise as we internalize what we've just gone through. Thank you.
Good morning once again. I think we've had a lot of tech speak. We've bombarded you with a lot of information. So before we go into the next section, which is more about telling you what next, how you sign up, sign on, about the cost of the platform, would like to do a short session, not physical exercise, but I want you guys to just remember what we have spoken about so far. So we've spoken about the rails, how anyone with an existing HMIS can be able to plug in, and how if you have a HMIS, you still need to walk through the compliance journey with BHA. And if you want to get a full HMIS, then we're able to assist you. So in the next 5 minutes, we are able to take 2 questions before we get into the Q&A section later on. So if you have a burning question right now or a burning comment, this is your opportunity to ask 1 or 2. Okay, Ben?
You just raise your hand, I'll bring a mic
Okay.
closer to you.
Yes, thank you. Gigi, don't ask us a hard question.
Morning. Geoffrey Gitagia, Group IT Manager for Avenue Healthcare. First of all, compliments to the people who worked on the system. I can see a lot of solutions were done. But I'd like to drag you into my operations. I saw the first screen for eligibility, and I think it's a bit lengthy. So in my facility, we have a patient kiosk where we can do eKYC for the patient, so removing a lot of workload from the reception. So is this an option we can adapt with your system?
Thanks, Gigi. I believe we had that conversation 2-3 years ago. The answer is still yes. And why Abid showed the APIs at the end was to communicate that, for example, your QMS can send patients into the queue straight from the queue management system. So short answer is yes.
That wasn't too hard, Gigi. Thank you. Anyone else with a question?
Hi, good morning.
Morning.
So my name is Kenneth Michoki. I'm the lead mobile developer at HealthX Africa. So I have 2 burning questions, very, very simple questions. So the first one is, one of the reasons why most, say, companies or clinical facilities build their own HMIS in-house is mostly for keeping the data in-house. So to what extent what options do we have for hosting data, for example? So you give us 3 options, that is adapt, connect, or replace. So what in those 3 options, what are the options that you're giving us for how you host our data? So do you host it yourselves, or do we also have the option to host it on our own in-house? The other question is, to what extent can we actually customize this product, this HMIS? Because looking at HealthX and what you're doing, we are mostly a digital first healthcare experience. So it's a telehealth experience. And the way our operations go, you find that there's some products that we have for our clients that are a digital first, and the rules for those products are very different for different clients. So that's also a very sensitive section for us. So to what lengths of customization can we actually customize this product to fit our business? So I think those are the 2 main questions I have.
Thank you. Ngure or Dr. Job?
Thank you. They're actually very pertinent questions. So I'll tackle the question about data across the 3 options. So adapt, connect, and replace. So for replace, it's a cloud hosted system, but hosted with Safaricom. And for us to keep the costs manageable, it's one giant cloud system, of course, with very strong partitioning between different tenants. Then for connect and adapt, which is where, let me begin with connect, adapt to the HIA. In that case, then your system stays exactly where it's running, and you modify your own system so that it's able to plug in. And it means that whatever decisions you've made in terms of where it runs remain your decisions. For the middle, the rail, the approach we normally take is to build a piece of software called an adapter, just like it sounds in plain English. It's a piece of software whose role is to connect your system to the cloud system. And it means then that the adapter and your system can run together, wherever your system is running at, and then the targets on the cloud. Then I'll mention also that the digital superhighway, the Kenya National Health Information Exchange, has a component that is regulated under law called the Shared Health Record, managed by the Digital Health Agency. And that component will require some prescribed patient summaries and similar data to be sent to the central national system. Then the question about customization. So the answer is yes, and there are 3 ways we think it can be approached. So the first, we did not go deep into clinical workflows on that demo that Abid showed, but we have something we call templates and template library. So it begins from the recognition that workflows in healthcare are so varied that no one can anticipate all of them. So the system includes a template builder and a workflow builder, a way to very rapidly put together your actual workflow, your actual clinical templates, and make them available to your teams. That's one option. The second option is the platform as a developer platform. So we didn't speak about it much today, but you could see that it has many apps inside one common app. And the intention is to actually be able to allow others to also connect and plug their apps into that. So you don't have to reinvent foundational things, billing and claims and patient registries and so on. And finally, the whole system is built to be API first. And it means that in a case, for example, like a HealthX, who is a telemed provider, we're able to work together and work out exactly how your system connects to our APIs so that the whole thing attains all needs. And I think there are very many exciting opportunities for telehealth providers, including being able to send orders and send prescriptions and send referrals into a national network. that connects the clicks to all the bricks that various hospitals here are actually providing. I don't know if that answered your question. Thank you.
Job, do you have anything to answer, to add? Or Julius? Or one more question.
Okay, good morning, everyone. My name is CPM Akan, Administrator, Gallants Medical Center. First and foremost is to thank Slade, Savannah, for being with us right away from 2014 until now. I remember Dr. Mudi, who visited our facility there at Rongai. He was just a slim guy that time. Today we've met physically again. I don't know whether you can remember me. He came with one insurance called Jubilee with a letter from Jubilee saying that we have been authorized to use our system. I was very hesitated that time, but he convinced me to join. But I'm enjoying the services from Slade. My question, I have two questions. Question number one is about multiple pair. You've actually demonstrated how it is done. My worry is about the unique number that we assign to this particular claim. If, for example, we have insurance A, B, and C, the three of them are actually using the same invoice number. How will this invoice number be differentiated when it comes to allocation of payments? Assuming that A has paid. Now, the same unique number is remaining for B, C, have not also what? Paid. What are you going to do? How is this system going to help us to solve that problem, specifically on unique number? The second one is about the claims that have actually stayed for long on Slade, on a state that they are actually transited to the pair, but they have taken like 1 year, 2 years. After that, the pair returns the same claims, saying that they were time barred. So I would like to know what is your role to ensure that these long claims that have stayed for long in your system are traced on time. Although we know there is what you call automatic reconciliation, yes, we have done all that, but the insurance, the payer takes long time to pay that. Now, what is your role here to intervene? Because they're asking the date in which we submitted the claims, of which we have also tried to link with your team, and they were not able to give us exactly the date in which we claimed. But on our side, we know very well that we do things within 24/7. Actually, we've lost a lot of claims because of such a case. What is it that you have to solve such a problem? Thank you.
Thank you. I'll go first and I'll answer the second question. So every payer has its rules. For example, if let's say I'm with a large private insurer like Jubilee, if a claim comes to us and we may notify the member if it's an inpatient, within 24 hours, it goes to the document queue. If it's an outpatient, within 30 days, it goes to the manual queue. Share on the other hand, the submission is very, for like pre-auth, it expires in 7 days. For claim, it's 14 days. Yeah, you have to submit within 14 days, otherwise it will auto expire. And then it will either enter clarification or a loaded queue. So the truth is that we did auto reconciliation after being told that the claim cannot be seen. In fact, a big word is used sometimes called untraced, but the truth is that it's in the manual queue. Because if that scheme is not underwritten, there's no way I can take it. If that newborn was just born today and you have dispatched the claim today, that newborn is not in that system. So it has to go to the manual queue. So that's what we usually ask our providers, to them to check the manual queue on their side. There's a document number. It's called DME number. There's a column for that, other than the payer reference number. Go then to the first question about different coordination of benefits, whereby you now have different payers, they are all not paying at the same time. In fact, we experienced that firsthand with SHA, whereby partial payments start coming in because PHC is paying maybe first the maternity, then you have PUMF, or maybe if it's an ICU, there's an emergency chronic FAD, or there's a PUMF, but they're all not paying the same time, yeah? So if you go and reconcile, then let alone you find another payment in your bank for which, but it was paid. So it's just that different FADs are paying at different times. So we'll have to agree on what standard initials, maybe via KKHF. And that's where people like Dr. Gakome are there to help, like in partial payments, whereby you have different fund, different insurers, is there a prefix needed? Because now they are not paying at the same time. In fact, they are different bank accounts. So you find that if it's a POMF, you found the money in National Bank. If you find it's the other side of ship, for the money from Equity or KCB, Nadescop, CDN, and the like. They're not coming from the same bank, actually. Different approval, different team. And how do we then check the auto-reconciliation in this service to be able to say that pass your first payment, pass your second payment, pass your third payment, pass your final payment, and the like, so that you don't start reconciling against the wrong fund and the like. So I think those are my answers. I don't know whether anyone else could add. Thanks, Julius.
Thank you very much, Daktari, for that.
Just morning, everyone. Just to add, with the collaboration that we're having today with Savannah from Safaricom, we're also bringing the financial muscle that we have at Safaricom. There are opportunities that we have of overdraft financing that is there. We have opportunity for invoice financing that will also provide. Even as a claim is being processed, the 90-day process, how can we convert it to, as Dr. Gakombe had mentioned earlier, same day, the same way that we get a transaction from M-Pesa. That's the role that we come to play in. And that's what the benefit that we get with this platform connecting to the rail. So those are the options we'll also discuss. And as we even come to your facility to demo, we'll be able to see what we can bring in and what more we can solve together.
Thank you. The last question or comment.
Thank you. Some of the questions being asked here are weighty matters, and some go beyond Savannah. They even go beyond Safaricom to national policy, to an all-of-industry approach. For example, the question of how to identify schemes, right? Each scheme should have a unique identifier. We've already solved that for doctors. Every doctor now is identified by their KMPDC number. Easy. Done. Every nurse by their nursing council number. Also done. Pharma, we are not there yet. I know the service exists. Adoption is still pending. Because it's by having those identifiers that we'll be able to agree how we handle invoices with multiple payers as an industry standard. How we assign who pays first, because providers here are suffering because insurers say SHA pays first. And then if SHA delays, we need to answer a national question, which is if a claim is not paid by SHA, if the insurer is not paying and the provider did not do anything wrong, who pays the bill? So I think this conversation should continue. And that's why I mentioned about my role in KEPSA and my role in KHF. With Safaricom support and with the bridge provider support, because Savannah, Smart, LCT, and others are bridge providers, we can sort out many of those questions so that we have commonality of references. And there's a big elephant in the room, which is the last thing I'll mention. When does a claim become revenue? Taxable revenue. How many of you pay tax? I know the faith-based not paying yet, but KRA may rebrand them. They now have to prove that they are really charitable. So if you pay tax, then the question of when a claim converts to a tax invoice is critical. And one of the solutions I'm hoping to get from Savannah is that the moment Jubilee accepts a claim, that is when the ETR is produced for the amount they have accepted. So that KRA does not come after me for money that I never got because half the claim was considered not payable. And it's even worse for doctors. When does a doctor's invoice become taxable? They bill through the hospital is here to collect. The patient was comatose, so they may not pay. When does a doctor become liable for tax? You said you're a CPA. We need you an ISPAC to define with KRA when does a claim become a tax invoice. So we have work to do, but together we can do it. Thank you.
Thank you. I think we can continue.
Yeah, thank you very much, Joy. Now, the question in the room is that all of us here are asking ourselves, what do I need to do to start this journey? So we're going to shift gears a little bit and have a way forward and the commercial engine of this whole process. Allow me to welcome Julius Maina. You might have started speaking before introduction. Julius, karibu sana. Julius is a senior business development professional and currently is the acting director, public sector, Safaricom. Karibu, Julius.
Good morning, everyone. Unlike Dr. Gakombe here, only have 2 titles, not maybe aspiring to have 6. So once again, as Nicholas has mentioned, my name is Julius Kinywa Maina from Safaricom, leading as the acting director for public sector, but my day-to-day job is a senior business development manager and a partnership lead. So it's a good engagement to have you all here. And thank you for the speakers who've come before. Very interactive session on the way forward for this service. As you've even seen from the demo that was done by Abud, the HMIS is here. You can see it. It was connected to the rail. It was demoed. So the question in the room is, this is no longer whether it works. Yeah. So it's what happens after this breakfast. Where do we go? What's the next step after this? As facilities owners, as administrators, as techpreneurs within the health industry. So to be more direct about it and how we see going forward is what decision that do you need to make as a team moving forward is do you make that early call that will cost you nothing, or will you wait and your competitors will be able to beat you to it and you lose the control that you might have by coming in early? So with that in mind, and with everyone in this room being here at 7 in the morning on a Wednesday morning, so means everyone here is interested, correct? Everyone here is interested. You've seen Savannah, great work done on the Slade, and you've seen Safaricom, the great work that we've done over the last 25 years. We bring in the 2 solutions together. We bring in what we want to move forward together as providers into this platform. So there are 3 things from you that you'll need for us to move forward. One is that decision maker, the person, the named budget holder of your facility. That one decision maker is the one thing you need, correct? 2 is that system that you have or don't have. As it was mentioned today, you adapt, connect, and replace. Yes? So that's the next step you need. And then 3, the committed window. So what is a committed window? The next 2 weeks, we want to come, demo to you, review your system, review your gaps, your processes, what you don't have, and we have convert it into a business proposal, convert it into a partnership that will work together for the benefit of you and also for the benefit of the whole health ecosystem. And today, as you register your interest, no costs, no commitment today. What do you need in this commitment? So today, what do you need? Is 1, make that call, make that path, and let's draft that plan together. We will be able to just highlight what the costs would look like. So in everything, nothing is for free, correct? So we will be able to demonstrate what that cost look like. From the speakers who've spoken before, we've mentioned at every table, there's a QR where you'll be able to scan the QR. Speak to us before you leave, walk through the journey with us so that you can take action today. And even as I maybe demonstrate what will be there as the pathway is, again, remember what we mentioned back. Adapt, connect, I can't hear you. Adapt, connect, and replace, yes? So those are the rails that will be able to work together. So that's a process that we'll be able to do. We'll be able to give a fair rate. We'll be able to give you the best solution that you'll see in the market. We'll be able to give you the best support that you see in the market. Every issue, not only healthcare related issues, all your system infrastructure issues, we'll be here to support. We've also committed, and as we've seen, claims is a big issue that is within the health industry. So we'll be able to offer the business loan, term loans, overdraft, invoice financing in the next journey that we work together. So within the next 2 weeks, please connect with us so that we can be able to kick off this journey and we'll be able to progress with this partnership. From here, we'll be able to hand over back to the team, but just a quick overview of what we'll see within the ecosystem. So we have 4 packages that we've lined up. All the way from an essential package that is targeting roughly a level 2. You'll have your consultations, prescriptions, claims processing. You have your full dashboard there. Storage, as was mentioned by a colleague, a gentleman behind there, will be able to support the storage element to it. We have a starter package that gives you a full clinical record workflow with the costing to it. We'll be able to support professional package for the facilities at level 4 going forward. And also we'll have the enterprise package, whereby at this level, we are working together to co-create, customize the workflows, connecting to the APIs that we were able to demo earlier on, that Abid had shown. We'll be able to do all this. So from this is a journey. So from essential, starter, professional, enterprise, where your facility lies on, we'll be able to connect you. And as your facility is growing, we'll grow together and to be able to move you to the next step as we continue this journey. So connect with us. We are around. We're here for any questions and looking forward to a great partnership. Thank you.
Thank you so much, Julius, for that. So as we almost come to an end of our breakfast meeting, allow me to introduce Lusweti, who will take us through the Q&A. Thank you.
Good morning, team. We are happy to see you here and feel most welcome. So for this session, we'll have a quick Q&A session, which will basically collaborate with my colleagues so that we can answer the question that you might be having. So feel free, just raise up your hand and we'll be able to attend to you.
Good morning. My name is Priscilla. I work for Maidawa. Are there any setup stroke integration costs? Or what we've just seen there is what we pay? I don't know. Who was presenting? Julius, yeah.
Okay, thank you for that, Priscilla. So as you've seen from the cost packages, there's a starter cost that you see all the way to the enterprise side. So there are some that you'll be able to start off without any setup cost. So it's a monthly SaaS product. As we continue to the last end, whereby we are customizing your workflows. At customizing, we'll be able to look at, those are the heavy machineries that we need to see, what kind of rails we need to connect for you, and what we set up. But for the other entry level or starter packages, there's no cost for setup. Is we come, visit, set up your workflows, and then we continue now with the SaaS that you pay as you use the service. The connect, sorry?
For connect option, if we just want to connect, we already have our system.
Yeah.
We want to connect. Does that still have an API integration cost?
Yes. So for connect option, as you've seen on the package, we'll have to do an integration. We'll have to talk to. We have to customize that together. If you have an existing HMIS and you want to connect to us, that one we have to sit down, customize it, and then now work through the cost for that together. Yeah, that one will be customizable. Yeah.
Just to add on to the pricing, you can go back to the pricing slide. So the way we have put it out is, it doesn't mean that if you want referrals, inventory, and revenue cycle, and you're level 3, that you can't purchase the professional suite. You can do that. So depending on what your needs are, that is what will place you at the different pricing levels. For example, my DAWA, you want custom workflows, APIs, and such. There's a cost for that. So the cost will be determined by the level of work. Yes, we do have our APIs published, but if you want us to create a special adapter to interact with your system, then we need to figure out what that level of effort is and cost our hours. But that is, I mean, we'll reach out to you and then we agree what that price looks like. But this is just to show you, depending on what your needs are, if you have a HMIS, I think you'd typically move to the custom side. If you don't have a HMIS, depending on what your needs are as a facility, then we would place you in one of these tiers or one of these buckets.
Thank you very much and good morning. My name is Isaac Mushiri from Smart Applications. And just to demystify something, is we are industry. We are in the industry together. We are not competitors. We are friends in the industry. We've worked together through this whole process and we are happy for that. So we've worked this journey with you, and our question is on the demarcation of responsibility. As a vendor, as also yourselves as a vendor, when claims are not being paid to the payers, where does our responsibility end? The system is submitting them as they are supposed to go, but SHA is not paying. Will the providers sue us or sue you for that matter?
Thank you. I forgot to add terms and conditions apply down there. And thank you. We collaborate a lot, just like hospitals do, either through CAF, RUFA, and the like. We collaborate a lot because these are industry concerns. Yeah. So one of the things that when you look at the contract hospitals have, which it's hospitals that have that contract, and then they are told there is a place that they need to connect to the national HIA. And as I've told you even last week, is that it's just a coincidence that we were doing HIA, and we're doing it especially for DHA and then SHA, and now also we have this product which we have. It's what is called advanced CRM, and some of you have had it for the last couple of months, and now we are launching it. I try to say this, that I try to have separate contracts. My contract with Safaricom, my contract with Apero, my contract with Jubilee, and then I go to the providers, my contract with Nairobi Radiotherapy and the like, which says that this is what I do, this is not within my, because sometimes, especially when you look at the public health insurer, some decisions are within branches, some decisions are within the county health management team, like licensing and the like. In fact, the closest I get there is support applications that I offer called it's called DHA Support App. Yeah? I think that's the one that sometimes, has a bit of licensing, onboarding, reinstatement, and the like. Maybe that's where people may interact with my services more when they're being onboarded and when they have support queries, or when support queries are level 3 at a product level. Otherwise, DHA Support App handles level 1 and 2. I know some of my friends would like me to handle their level 1 tickets, but they only come when there's a product failure or there's a release that's not going well. I think I would like to say that we respect the contracts that are there in the industry. We always have to educate ourselves on that we are not underwriters. Sometimes our balance sheets may not carry even some of the transactions that we see, but going forward, even as we work with Safaricom, we hope also to be able to come with better industry standards so that people know this status. Whether they see it on my side or Smart is the same status, it means the same. If a reconciliation says this, it means this. And especially now as we go forward adopting the name client registry number, the same corporate code, the same terminology services for codes for various drugs and lab and the like. It will get easier. And I like the way we are collaborating, even as we help our providers navigate through this very complexity. And the fact that when you are a vendor, most of the time you are in custom workflows, API, your own HMIS, or if you want to white label certain workflows and the like. Thank you.
Good morning.
Morning.
My name is Sami Mutai from Zona Imaging. Still stuck at the cost, the pricing. When you talk about the seats up to 50, is it the licensing per person or am I paying based on the modules?
The licensing is not per person. So, for example, if you're professional and it's 48,000 per month, you can have 50 seats, 50 people using the platform at the same time.
All right.
Not at the same time. 50 licensed people, 50 accounts created to use the platform.
Okay, I'm still holding the mic because I had another question. Regarding data storage, we've experienced the changes from NHIF to SHA, and we actually had a lot of data that we can't access right now. We can't basically reconcile. Is Slade going to be in charge of our data, and can we access, knowing that probably the administration may change next year, you never know, and somebody may come with new ideas? Are we safe? Are we sure that we'll have data that going forward we can reconcile?
Yeah, so thanks a lot. So it's a SaaS product, and you not own, but you control the data in your account. So while the data on this side that has not gone to whichever payer, you will still have that record indefinitely for as long as you have the account. Yeah, thank you. Any other question? I might to John there.
Hello. Hello, my name is Kennedy. Thank you. My name is Kennedy. I represent Kafrik Center. We are a mental health hospital. And my question is specifically for the connect option. So if you already have an existing system and you choose to connect, especially for the claim management and the billing and admin modules, does it mean that as for our system, we'll be paying DHA for the certification license and also now paying Slade for this? And also, if we connect, will the costing consider the costs that are incurred? Thank you.
Thank you. So the question about payment, will you be paying DHA for this and paying for the rail? I think the answer is yes. The DHA fee is statutory. And then for the rail, we'll work with you on the fee for the connect. That was a question on payment. Is another the other one was? Huh? This was payment.
Good morning. Thank you for this presentation. I think it's very timely. My name is Dr. Dennis Ogola, Managing Director at Equity Afia. Providers lose a lot of money to payers due to basically incomplete claims or claim submission. And payers now are using AI to vet claims and automate rejections. As providers, I'm just wondering, to what extent are we also implementing AI to be able to just make sure that before the claim is submitted, then everything is in order, claim forms have been checked, so that we basically prevent that loss that we are experiencing? Thank you.
Thank you, Dr. Ari, for the question. So one of the things we are building on the rail, and we want to work with you on that, it's something we're calling pre-flight. So for a long time, there was straight processing at payers, rules and AI at the payer. We want to bring it as close as possible to the providers, meaning pre-flighting before dispatch. And if you go with an option where we have a deep connection or replacement, actually at the point where your billing officer is billing the patient.
Morning, everyone. My name is Kalpana. I'm from MP Shah Hospital. I have two questions. One is related to what our friend doctor has just asked with the AI. So my question is a bit more elaborated to it, that what happens is we have submitted everything as needed, but it still goes straight into rejection and there is no way we can reverse it. So we really need to have a way of adding something or editing or reversing, because we have given the services. So I don't think it is fair on us to have a straight rejection without giving us an opportunity to resubmit. So do we have a provision for that? Secondly, my other question is that what my other friend had asked, my question is that are we actually migrating the SHA information into this new, or are we going to be left in the limbo the way we have been left for NHIF? Nobody is actually taking up NHIF seriously, and all of us sitting in this hall have money that has been sitting. We don't know whether we are going to be paid or not paid. Promises are made, but are we going to lose SHA money that we have incurred in the previous system? So we need a clarity on that.
Thank you. I'll talk from my experience looking at this product, because Share Provider Portal was built on a Slade license, and we built that. Once the claim gets to the payer, and let's say for maternity and a bit of dialysis, and now maybe others are going there, AI gives to the manual queue if, let's say, it misses. Sometimes there's a speed at which maybe a manual people would be and doing things. And my ask is that we keep on lobbying, especially through the branches like for you in Westlands, and say, okay, there you said no document attached, but was there. And also I think for us, it's also to lobby with our peers in the whole value chain from Safaricom and the like, that if you say you can't see a dialysis chart, then the dialysis chart should pop up and take the whole screen or something like that. I think that's the first thing, that there are things to do both on the lobbying and also at the association side, whether it's Kenya Reno or also KHF and the like. That would be important. Second thing, noting that, as I said earlier, we built the provider portal. We worked with Safaricom on middleware and terminology services and many parts, biometrics for the HIE. We see an opportunity to make integration and also migration and data seamless. I think we owe that to the industry to work on that. And I think we also know that KHF is talking to the relevant stakeholders on the reopening of the NHIF portal. I think for reconciliation, I think Dr. Kobe can comment more on that. Thank you.
Thank you, Dr. Muthe. Please check whether that portal is open. We met the CS last week, and they had agreed to reopen the portal so that those who had claims that were pending can deal with them at this point. Two, for those who were asked to sign off and they were not happy about the amount they were asked to sign off, there is an appeal process coordinated by CAF and KHF. Please convey your sentiments, because we understand there were people who were told, sign here, and they felt small relative to SHA, so they signed. We want to add a little bit of muscle so that we can lodge appeals. 69 appealed. If you need to appeal, Dr. Musawa and his team, supported by us, are available to help. But that goes to a question that was asked earlier, which Dr. Muthe has clarified for me. It is important that providers can maintain evidence of claim delivery, so that when a portal is shut down, you still have proof that you did deliver a claim. Because we have suffered where the system belongs to the payer, then the payer decides to move on, and they shut it with our data. And it's not just NHIF, there are other even private providers who shut down their portals. And you suddenly find that as a provider, you are holding nothing because everything was digital. So whatever is done, those who are providers like me, let's insist that you must have a complete record of that which you submitted, so that if push comes to shove, you can provide evidence. To my brother, Dr. Nyangena, every time we get M-Pesa, you get a message that whoever you are paying has received the money. And I'm sure if you remove that message so that we do not know whether we have paid, the number of fights in this town would be very, very, very many of people saying, sijapata hiyo pesa. So whether it's a vendor who is being paid by a till or a pay bill or an individual, there is always a confirmation message that the money has been transmitted. In fact, you've gone further so that when we pay through the bank sends a message and the vendor sends a message and the system is transparent. So in the same spirit, is it possible that the patient who sought services at Metropolitan also keeps getting a series of messages? Your claim has been accepted. Your claim has been returned. Your claim was rejected. And you should therefore make arrangements to pay the provider. Because we should not stop at simply saying your treatment was pre-authorized. One needs to know the outcome. And that will help solve a question of fraud. Because if we genuinely and truly treated someone, that person should be able to help us say, I am not a ghost. I was treated. I have a hip replacement. You can x-ray me as evidence that I am a SHA member and I did get treated. Because at times, we are being left in a very difficult position. You treated a human being who you can identify, who you can take into an MRI to confirm you did serve them, and then someone says that claim is not payable. So please create a system where we have full transparency from authorized to paid or not paid. And that also prevents us from going back to people to demand money after we were paid, because some people may be unscrupulous and say your claim was rejected by Jubilee, so pay us, and they have no way of confirming whether or not it happened. So whatever you've done on M-Pesa, we want the entire suite that's applicable to be applied to medical claims, and that should raise the degree of trust. Because one of the things I'm hoping your partnership will do is to attract a very significant trust deficit between payers and providers, where payers see us as perennial thieves who are looking for every opportunity to part them with their money, and we see them as people who are looking at every opportunity to run away from financial responsibility. So mutusaidie hapo sana.
Thanks a lot, Dr. Gakombe. And our commitment, our vision actually is grander. We want to have the same impact we had on financial services in health. And this is the first step. Of course, we're going to get into pharmacy, we're going to get into the actual client. They'll have an app that will be able to interact with the entire ecosystem. So we're building the ecosystem. And for the providers, I know we have a short timeline that the government has given, but the beauty, or one of the interesting things about sending your claim directly from your HMIS is you have your own record. So you're not logging into the payer's system to do your claim work, and then if that is shut down, then the data is shut down with it. So if you send your claim directly from your system to the payer, then you have a record. And it's going to be confirmed through these pre-flight checks that Dr. Ngure is talking about. We're going to get confirmations and all that. And these pre-flight checks, it's an evolving thing because, especially SHA, rules are changing every day on what is acceptable. So to prevent rejection, we're constantly checking with what SHA is saying and with other payers, so that by the time the claim leaves your platform, then we're more or less sure that it will be accepted, because the pre-flight checks make sure that everything that is demanded by the payer has been catered for. Back to you, Joy.
There was one question that was left. Ngure, you can tackle that.
Thank you. I think Dr. Job and Dr. Kombe have already answered most of it. Mine is very simple. At a technical level, when you move from portal to the rail, we'll commit to work with you to make sure all your data is preserved.
Good morning. Thank you for the invitation. My name is Dr. Jean Kula. I work at Penda Health. I also serve as the chair of the Digital Health Committee, Kenya Healthcare Federation. I have 3 quick questions. First, you described the SaaS model. Is there a world in which you have like a lump sum payment, so like a total cost of ownership type of model? The second, given your deep expertise, are you going to be hand-holding providers, vendors through the certification process? We have a lot of members who are really struggling with that process. So does that come as part of the package or is that separate? And third, asking for my members, just given the really high cost of doing business, every week we're being hit with a new bill, a new body, a new cost for certification, for licensing. So is there a way in which you can have some sort of discounted package for our members? Thank you.
Thanks a lot. So given that it's a SaaS model, there's no option of a one-off payment because we are hosting for you. There's running cost, there's maintenance. So you can currently you can only use it from the cloud perspective. Number 2, and maybe it's something we should consider as a separate package to help vendors or providers who have their own systems to certify with DHA. But that is something we'll have to consider separately based on our experience with Digital Health Superhighway as it's been set up since we were part of its development. But we've not sort of concretized it. So it's yes, we can support. We just need to work on the framework for that. Yeah, thank you.
She has one more question. Oh, you're good? Sorry? On the discount, to be discussed. Terms and conditions apply.
Sorry, on the discount, I'm the terms and conditions guy. So we'll discuss. It's a partnership, yeah. So let's discuss. The terms will. I know Mother is looking at me, but we'll discuss.
Good morning, everyone. My name is James. I've got 2 questions. I had 4, but 2 have been answered. One, I'm curious to know what data is being transmitted post-integration, particularly to SHA or the healthcare HIE or something. And in this case, I'm actually curious in a situation where a multiple payer patient having SHA and insurance XYZ, which information is actually going to SHA? Is it both clinically and non-clinically? I'm curious to know that too. Going through the demo that Abid presented, I wanted to hear something about the diagnosis, where I understand SHA wants the ICD-11 diagnosis. I'm curious to know the industry alignment, particularly from the insurance side, who I think at the moment they're still on ICD-10. So how exactly will our teams navigate through that? I think those were the 2 questions. Maybe the last one about the already existing data that is now SHA, exclusive on SHA. And I appreciate what Dr. Kagombe has said, but on maintaining records of those, they already submitted claims, right? Currently, you can only export that from their system. Doesn't have a letterhead, doesn't have anything. So as much as you might have that data, there's a likelihood that they may as well disown it, right? So I'm curious, much as you could have export the data from for instance, the current SHA system, as the claims that you already submitted, it doesn't have a letterhead, doesn't have anything. So justify them saying it wasn't their data could be a little bit of a question. And riding on what was earlier said, that Slade, or rather Savannah, was used to subcontract SHA, development of the system. I'm curious, post-integration, what happens now to the existing data on the currently running SHA system? Thank you.
Very quick feedback on the ICD-10, ICD-11. Insurance companies are regulated by RA, and we are regulated by KMPDC, and the Ministry of Health has agreed to align with the Ministry of Finance so that there is one code. Remember, the HIE is about one code for anything. So if it's diagnostic codes, there should be universal across Kenya. So that's work in progress. I don't know at what point they'll agree, but DHA is approached IRA to get the insurance companies to use ICD-11 as a regulatory requirement. So I hope that will be solved soon.
Just to add on the ICD-10, ICD-11, from our experience with the private health insurers, there are some that have capacity to consume ICD-11 codes. It's just that they were waiting for all providers to move to ICD-11. And it shouldn't be, for example, I know one of the ones that we work with can take ICD-10 and 11. So it will just be for the facility to say that now we're using ICD-11 and you move. But as Dr. Gakombe has said, there needs to be an industry standard that everyone adopts. Ngure.
Thank you. So the question on what is sent to SHA, the short answer is, first, claims and pre-authorizations and everything required to support them. That would be the clinical information that's part of supporting it. Then on the HIE, there's something emerging called the shared health record. And the shared health record is defined by Kenyan standards. I think we should be publishing them soon, Dr. Job, with DHA. And those Kenyan standards, they're called implementation guides, are defining for the country what's the shape of a referral, what's the shape of a test order, what's the shape of a prescription that can be sent and understood by every other system. And so it's the shared health record with defined public standards that will commit to, with DHA, sensitize the industry on claims, pre-authorizations and everything required for them, and also prescriptions and referrals and orders. Then on the question of coding, what I'd add, picking on what Dr. Akombe said, one code. So we are very focused on diagnosis because diagnoses have always been very visible in our claiming journeys. But there's another very important part that we should work as a sector to standardize. And that is standardizing the codes used to identify products and services. So there is something that is built on the Superhighway that's called a terminology service that is defining standard Kenyan codes for medications, for devices, for tests, and for procedures. And if we manage to get our systems to understand and speak that language or to map our existing masters to that, then we'll have taken the single most important step in preparing each of our systems to talk to other systems, whether built by our teams or other teams. So I was just sensitizing us that beyond diagnosis, there are other code sets or master lists. Then on the subject of exports tracking and existing data, so I'll repeat the answer given, then add something. So we'll commit to work through the HIE to ensure that pre-existing portal data is preserved. Then when it comes to how to avoid being told we didn't receive this, one of the things we've for long built into our systems is a way of tracking end-to-end that also includes attaching to that claim identification numbers from the destination or payer system. And it means then that the views that come to you are not just the claim with your invoice number, ours, also the claim with the paying system's invoice number. And it's bundled into a service we call auto-reconciliation, that on this partnership in this rail, we're going to strengthen even further with the viewpoint that auto-reconciliation should work across all your credit payers and help you track and break down where everything is across all your payers. Thank you.
Hello, everyone. My name is Dr. Mude Tony. I'm a dentist, and I also run a multi-tenant specialized HMIS system for dental clinics. My question is in regards to the costing. I imagine that for such a system, we need to do a one-off integration for the whole system. But how do we envision the costing to look like? Is it for the whole system, or it is per the tenants who opt in?
Thank you, Dr. Mude. So for the one-off integration on the custom enterprise package, that's something we'll still need to work together and frame it out. But for the other packages, once you come in, it's per the module that you choose on a monthly basis. We'll be able to give you that services and the options that are there. So for those who have a rail that they want to connect, maybe another HMIS, I know people have asked about getting a one-off payment for that connection. Still being a SaaS solution, it's something that we need to discuss. But as of now, it's a recurring kind of cost model that we've already built into our system. Yeah.
I understand about the subscription being ongoing. My question is, the system runs on various clinics, and each clinic have their own sub-account under my platform. Will they be paying for their own subscription, those who opt in, or is my system paying one-off?
Yeah.
Or rather monthly subscriptions?
Yeah. So there are various packages. The light packages whereby it's per a clinic. And then as you go to the further packages is where we expand by multiple facilities of clinic. So if you look at that cost pricing, if you go back to it, we've also set the number of users and also set the number of, we'll add the number of the clinics that you can be able to have or facilities into each module. So the first one and the second one, largely that is per facility. And then we'll also be able to communicate the full package list on the number of facilities that it supports. So there are modules that will support more than one facility.
Hi, my name is Purity from RFH Healthcare. On the matter of rejection, with the current system, we are experiencing a number of rejections because they are mostly handled by the AI. And in such, you can get situations where you're getting a rejection because of a missing claim form. While me as a service provider, I've checked my claim, it has all the documentation. With the current system, it's more of like a suggestion. After like the rejection, can we have like an appeal button in such a way as a service provider, if I check my claim and it checks all the required documents, I can be able to appeal, rather than every time we are required to like write emails for like an appeal, and probably nothing is gonna be done about that. And on the second issue, it's a matter of on communication. With the current system, it has run on more of implementation than communication. So you wake up in the morning, you find the system is different, you're stranded, you don't know how to go about it. With the new system, can we have a communication implementation system running?
I will answer the second one. So we tend to write most of those release notes, and they tend to get a window that is okay. You need to understand that there is about 200K to 300K visits on the SHAP provider portal every day. That's the one thing we also need to understand, the burden that is there. And the release window is so narrow, it happens at 1 a.m., maybe to 2 a.m. And for emergency providers, we tell you when they meet it, when we're doing the upgrades there, it's a bit inconveniencing. Now, we try our very best to document everything in that release note and to beam it through Beamer in the morning, that you have to click that Beamer post telling you there's a new release. Yeah? And of late, we give very good examples and scenarios. Now, one of the things that people ask us is that since also we have the UATs, especially when you look at RFH and we're working with you on oncology module, how do we get people to know what we are working on and what we are finished working on even before the race? Like how do you express training site a bit earlier? And I think that's also the same thing our vendors, partners in this room are asking. Tell us when you are almost finishing the dev stage before UATs and the like, so that also they can have their balloting and recommendations and proposals early on. Now, what I can say is that now, as we work on this, we try our very best to have a training version early on, because that helps people. At least you can be way ahead of what we are doing, so that you don't wake up and oncology prices have changed. And now back to your other question on AI rejection. No, that's a policy question. Like for now, with a private insurer, you can appeal and we can add that. Because the policy is that you can come for reconciliation and then you do reconciliation. In fact, you know who they are. On the other side, maybe a public insurer, the current policy, rejection is a final state. So it being a final state doesn't have resubmission. In fact, sometimes when you look at the AI, you'll actually, if you go through the transition logs, you see AI sent to manual review. It's not AI approved or AI rejected. It's manual review, meaning that there are humans that went and said, maybe that form is not there. And that's what we're saying as a policy. How do we create more evidence? If I say dialysis chart is not there, it pops up. So it's a policy that means to meet a technology solution. If you select something, it's like something we have observed. When people do pay authorization on the Slade system, it always happens that there is a device that is connected and is blinking green. So anytime you say that device is not working, it tells the insurer that the device is connected, is green, not red, with an X. So that now there is human proof what you're saying is actually correct. I think going forward, there'll be more of this as well. And I like with the support from KHF and the association that this meeting happened, so that we have more of this, so that also policies meet technology proposals, so that all vendors meet and the like, and we agree on common roadmaps and the like. But my commitment is, especially now that despite sometimes the release notes, you know, the people who got it were the night shift, wameenda nyumbani. In fact, they clicked it. The moment they clicked it, it marked itself as red. And now the new guys come during the daytime shift, people come and that banner is red. So I think we need to do better. We need to connect better. We need to figure out how to have the in tandem with the live production. How do we have the training, especially for your vendor partners, and so that you can also train people at the earliest that particular application. And I've seen that with oncology, whereby for the new oncology process, we have gone around, at least my team has, together with our stakeholders, and tried to tell people, this workflow is changing this way, the tariff is changing this way, and there's a pricing that's changing this way. Thank you.
Okay, I think we can wind up a large Q&A session. What I would ask, I know we still have burning questions, but we will maybe want to answer them one-on-one. I ask that the Safaricom team and the Savannah team to please stand up so that people know how to reach you. Dr. Fred. And guys, please stand up so that our team can reach out. So if you have any questions or any concerns, please reach out to any of my colleagues here. They should be able to answer your questions. In addition to that, we do have the QR codes that we have been mentioning. They are all on the tables in front of you. Please scan and book a one-on-one session with one of our colleagues. We'll reach out towards as the day proceeds, and then tomorrow as well. There's also the option, as I had mentioned when we were starting, if we have made you feel like you really need to get onboarded right now, there's also the onboarding part of things. For those of you who are online, we will also share a link on how you can reach out and show interest. Thank you. Guys, we can sit.
Thank you very much. From expectation, the first time we started, I think 85% to 90% of your questions have been answered. Those who are expectant, you're almost there, right? Yeah. So it has been a beautiful morning. We've had a lot of conversation, and this time round, I would like to ask everyone to remain behind. We'll have a photo session, a group photo session here. Then we'll have another one outside. But meanwhile, we'll want to give a gift hamper to KHF leader, and we'll invite Dr. Mdet to come and give so that we have a photo session here. Gift hamper.
Thank you. Allow me to present our gift of appreciation to Dr. Gakombe. And sorry, we only sent the invite 2 days ago, but we'll become better. We'll be doing training before we go to production as we go forward. Yeah, so thank you. Thank you.
Hiya,
So much.
cameraman.
Yeah.
Be ready, cameraman.
Oh, you want to someone here? Okay. Thank you, Dr. Gakombe.
Makofi.
Thank you.
Asante sana daktari for coming.
Yeah.
Thank you very
And
much.
then the next one is for Jean Chula, the Digital Health Committee chair lady. Thank you. Very good, Jean.
Yeah, take a very good photo for that.
Yeah,
Cameraman,
thank you.
Makofi.
Shukran.
Asante sana. And everyone else will get a gift hamper after this. We're going to reward everyone. I said at the beginning, there is nothing for free. Even learning, you need to pay attention. You already paid that attention. We'll give you back a gift hamper. So a reminder, we'll have a group photo here after we close. Then we'll have another one outside. Remember to network. Don't get out of this place without knowing a gentleman in this room who has 6 titles. I've had another one has 3. We have another one here who is a director in a big company. You need to network and get contacts for that. One thing that I've learned from this session is that apart from you having your processes simplified, a patient has full control of the record. So there is no way that matter of just getting a record from a file and running it away with it without consent of that patient. Now, patient will have to consent before you handle the record. Consent management. On behalf of Savannah and Safaricom, we greatly thank you all to coming and honoring our invitation. We are greatly honored, and we believe through innovations, collaborations, and all this initiative will get us to greater heights. Karibuni sana and have a lovely day. So those who are taking photos will come here, arrangement. They are experts in arranging the stage. The taller guys will go behind. People will line up. I don't think all of us will fit here. There's a lot of weight.
Okay, we'd like to invite all the speakers. Please come to the front.
Those who've addressed the congregation on the stage.